So today we are going to start the pathology of GIT, and I'm going to take our organs in the reverse fashion. For example, from the large intestine all the way up to the oral cavity. Our first organ is appendix. It is a tube diverticula that is present at the lower part of the cecum. And there are many diseases, but the most common disease that we are going to encounter in our clinical wards and all that hospitals is our acute appendicitis. So first we are going to start with the epidemiology, that it is present mostly in the young adults and in children. And about 7% of our population is at risk for appendicitis, and it is more common in males. So the diagnosis is very difficult to make before the surgery, because mostly like my teacher told me that appendicitis is an operation that whenever a surgeon goes into the operation theater, he's not confirmed that he's going to find an appendix, and he's not even sure that he's going to find an inflamed appendix, because there are very many DDs for that. For example, mesenteric lymphadenitis, acute salpingitis, ectopic pregnancy, or the pain associated with menses, and Meckel's diverticulitis. So when we talk about the pathogenesis of acute appendicitis, we see that it is due to the presence of a fecolith or any lymphoid hyperplasia in the mucosa or the lumen of appendix, and this entrapment causes obstruction in that lumen, which will cause an increase in the intraluminal pressure and will cause to apply pressure on the nerves and the blood vessels that are along the appendix. So if the nerves are compressed, it will cause pain at the McBurney's point, and if the vessels are compressed, it will cause ischemia. So the luminal obstruction that is due to fecolith, it could be due to a tumor, gallstones, or worms. These are going to cause inflammation. We also know that the appendix mucosa secrete mucin that will keep the bacteria away from the mucosa. So the mucin is going to get secreted, and the bacteria are not going to go out. So there will be accumulation of mucus and bacteria within the lumen that is distal to the obstruction. If that appendix ruptures, it is going to cause appendiceal abscess, and if it ruptures, it may also cause peritonitis. So the pathology is going to be associated with a tissue edema, neutrophilic infiltration, because it is acute inflammation, and this infiltration is going to be in the lumen, muscular wall, and all the soft tissues that are near the appendix. The morphology shows subserosal vessels that are congested, and there will be neutrophilic infiltration in all the walls of the appendix. Plus, the serosa is going to get dull and granular appearing. The mucosal neutrophils and the focal superficial ulceration is going to be present, and the diagnosis is mostly confirmed when the neutrophils are found in the muscularis propria. So I told you that the mucus is going to get accumulated in the lumen. So if that causes a focal abscess, it will cause acute suppurative appendicitis, and if it causes gangrene and ischemia, then it will be complicated by the disease known as acute gangrenous appendicitis. So the clinical features that we see in that patient are going to be periumbilical pain. That is the most early sign, but it is not obviously very diagnostic, because periumbilical pain can be due to many reasons. It is also associated with right lower quadrant pain, nausea, vomiting, low-grade fever, because obviously inflammation causes fever, and an elevated WBC count in the peripheral blood. There will also be pain in the McBurney's area that is located 2/3 of the distance from the umbilical and the right interior superior iliac spine, and this is known as McBurney's point. So this was our total acute appendicitis disorder, and this can be treated with surgical resection. Then we are going to study about the tumors of the appendix. The most common tumor of the appendix is carcinoid tumor, that is a well-differentiated neuroendocrine tumor. About 50% of the appendix tumors are carcinoid. The most common site is the distal tip of the appendix. This is a very high yield point, and appendix tumor is like a swelling about 2 to 3 centimeter that is present at the tip or anywhere, but mostly the tip. The next thing we are going to study is adenomas or non-mucin producing adenocarcinomas. These also occur and can cause obstruction, and this can have a differential diagnosis of acute appendicitis as well. Like I said, that the mucus is being secreted, and if the appendix is filled with mucus and causes rupture of the appendix, it is going to get out and cause peritonitis. Likewise, it may also cause mucinous cyst adenomas or mucinous cyst adenocarcinoma. Then these may go out and cause intraperitoneal seedings as well. In women which have peritoneal implants can be mistaken for the mucinous ovarian tumors as well. And in most advanced cases, these the abdomen gets filled with mucus or semi-solid mucus, and this condition is known as pseudomyxoma peritonei. And this condition is a very disseminated intraperitoneal disease. So we can only get it checked by repeated debulking, but it is almost fatal in most of the cases.